everyone, and welcome. Thank you for joining us today for our BRYCS Community Conversations, an introduction to female genital cutting, and for your interest in this important topic. Just a few items before we get started. If you need help troubleshooting during this presentation, please use the chat box on the right of your screen or email info@brycs.org, and we will answer those quickly. Today's webinar will be recorded, archived, and made available online 24 hours after the event. Registrants will receive a follow-up email with a recording, copy of the slides, and any supplemental materials. You can also download the PowerPoint and our backgrounder on female genital cutting via the file share pod in the bottom right of your screen. A Q&A session will be held at the end of this presentation, so please use the chat box on the right to submit your questions. Any unanswered questions will be posted and responded to on our BRYCS blog, which we've provided a link to, and we encourage you to continue the conversation there. At the close of today's presentation, you'll be redirected to a short evaluation. Please take a moment to provide your feedback so that we can continue to meet your needs. And without further ado, I'm pleased to introduce our speaker for today, Jenny Siegel. Thank you for taking your time and sharing your expertise with us today.
All right. Good afternoon, everyone, and thanks for joining today's webinar. As Alyssa mentioned, my name is Jenny Siegel, consultant with BRYCS and also a PhD student. I also used to work for USCCB, so my name may be familiar to some of you. So it's good to be back online with some of you. And thanks again to everybody for joining and for your interest in today's conversation. As Alyssa mentioned, I will do my best to get to all of your questions today. Please put them in the chat box, and if I don't address them today, we'll get to them later through the BRYCS blog format. And today is just an intro to female genital cutting, so I'm only going to hit the surface on a lot of different topics. So stay tuned for more resources and other webinars through BRYCS Community Conversations. Today, I just want to affirm that the subject matter is sensitive and descriptive, and it may be somewhat difficult to hear. I also want to affirm that there may be someone listening who has undergone FGC. If this is you and anything you hear from this webinar triggers any sort of emotional response, please feel free to connect with myself or my colleagues at BRYCS offline, and we can certainly get you connected with resources in your community and would be happy to talk with you more about this. But as you can see on the slide, here's an agenda for what I plan to cover in today's conversation about female genital cutting. So I want to start with a quote from Jaha Dukare. It says, "There is such a culture of silence about FGM. If you stand up and say, 'This happened to me,' people will scrutinize you. But someone has to stand up and say, 'This can't go on happening. This is a human rights abuse, and it has to stop. Until the education of a girl is a right and not a privilege, we are failing our women.'" This is a quote from Jaha Dukare, who's a women's rights activist who speaks out and campaigns against female genital cutting. She's from Gambia and is a survivor of female genital cutting from when she was an infant. And we're going to unpack some of the themes in this quote through our webinar today. So first, what is female genital cutting? It's defined by the World Health Organization as the cutting, pricking, removing, or sewing closed of all or part of a girl's external genitals. It's performed on girls from infancy to early teens, depending on the culture. Most commonly, it is performed on girls between ages 7 and 11. It is referred to by many different names. For example, in the Maasai community, they may call it Suna. Bora ethnic groups from India and Pakistan may call it Katna. And one thing I just want to point out is that for the purposes of today's presentation, we will call it FGC for female genital cutting. The World Health Organization refers to it as female genital mutilation, but in many communities, this term can sometimes be offensive because it implies that they're abnormal or have been mutilated. And it's also a term that's been developed by Western countries. Female circumcision is one of the most widely known and accepted terms in communities who practice this. However, I just want to point out that this is not a parallel to male circumcision, as it has serious health consequences and suppresses female sexuality. Female genital cutting is internationally recognized and globally condemned and considered a gross violation of human rights, gender-based violence, and child abuse. FGC predates any religion and has its origins in ancient Egypt. It is practiced all over the world. It cuts across race, class, educational, and religious backgrounds. Most commonly, it is practiced in East and West Africa, the Middle East, and some Asian countries. Because of diaspora and immigration, it is increasingly practiced in European countries, Australia, Canada, and the U.S. It is estimated that approximately 200 million women and girls are affected by the practice worldwide. And the CDC estimates that around 500,000 girls are at risk for FGC in the U.S. This number is estimated based on the number of immigrant and refugee communities in the U.S. who come from cultures that practice FGC. And this map highlights the prevalence of FGC around the world. Red marks countries that most prominently practice it, and green is where it occurs the least or never. Some countries most affected are Somalia, Eritrea, Kenya, Congo, Sudan, Ethiopia, Egypt, Iraq, Yemen, Pakistan, and Thailand, just to name a few. The reasons for the practice vary depending on the culture. Cultural traditions are generally the major reasons for the practice. It is done to promote chastity. In this sense, it suppresses female sexuality and maintains control over women's reproductive organs. In some cultures, an uncut woman is not considered an eligible marriage partner, and it could be grounds for divorce in return of any dowry payments. Another important factor is that in some communities, women are not able to engage in public life unless they have been circumcised. In this case, it also preserves family honor. There's no evidence that any religion condones the practice, though in some cultures this is used as reasoning. However, religious leaders in Christianity, Islam, and Orthodoxy have spoken out against any religious justification for the practice. On this note, I also just want to point out that this is not just a practice in Muslim traditions, which is a prominent stereotype, that there are some Christian and Orthodox groups who also practice FGC. Importantly, a major reason for the practice is that FGC marks the rite of passage into womanhood. Many non-Western cultures mark this as a clear transition, and FGC is a part of that. However, it doesn't have to be, and we'll talk about that a bit later on in the webinar. A couple other things worth pointing out about FGC and the complexity of addressing the issue is that though the practice is harmful to girls, often mothers' decisions to have it done on their girls is not out of malicious intent. There are instances where girls and families can be excommunicated from their cultures and considered to be unfit marriage partners if FGC is not performed. So I think it's worth noting for social workers and others working with girls affected by FGC that prevention efforts are very complex. Now I want to talk about the types of female genital cutting. The World Health classifies 4 different types of FGC. Each type has varying degrees of health and psychological implications, and the type practiced simply depends on the ethnic community in which it's practiced. So type 1 is often referred to as a clitoridectomy. Sometimes it's also called SUNA, and it typically involves the removal of all or part of the clitoris, and sometimes the prepuce or the fold of skin around the clitoris. Type 2 is referred to as excision. It's similar to type 1, except that the labia are removed as well. So there's a clitoridectomy and the removal of the inner labia, and sometimes includes the removal of the outer labia as well. Type 3 is often referred to as infibulation. This is the most severe and extensive form of FGC, and it involves the removal of the medial parts of the inner and outer labia and the joining together of the sutured parts to create a narrow opening. When the procedure heals, a scar forms a seal over the vagina, and a small opening is left for the passage of urine and menstrual blood. Sometimes this opening is as small as a pea. Type 4 classifies other variations of FGC. Sometimes this involves pricking, piercing, stretching of the clitoris or the labia. Sometimes coercive substances are introduced to cause bleeding and a tightening of the passage. FGC is generally performed by traditional healers and midwives in communities. Often they use blades or other unsanitary tools to perform the cut. Though this is condemned as an unhealthy practice, around the world we are seeing an uptick in the medicalization of the practice, where physicians and medical professionals are performing FGC in a controlled medical setting to prevent some of the harm. In the U.S., we have also witnessed this. The medicalization of FGC is still considered a violation of human rights, and it is still a harmful practice. And though some of the short-term health implications are prevented through the medicalization of FGC, it's still harmful in the long term, and the effects can still be irreversible. Some of the short-term health implications of female genital cutting are excessive bleeding, shock, extreme pain, infection, including sepsis or tetanus, urinary problems, and death. There are no health benefits to FGC, and it is harmful to women and girls, and the health implications can be lasting and irreversible. That being said, FGC also has long-term health implications. This could include chronic infection, obstructed urinary or menstrual flow, cysts, pelvic inflammatory disease, difficulty or pain during intercourse, infertility, complications during childbirth, and an obstetric fistula. Women experience varying health implications depending on the type of FGC that they've had performed. And it's important to understand that women don't necessarily connect these health problems with FGC, and it's not necessarily realized that these are related to having undergone FGC. There can be a lack of knowledge of the implications of the practice and the female anatomy as a whole. Therefore, education on these topics is very important, especially by a healthcare provider. I also want to quickly address what's called deinfibulation. This is the cutting open of a type 3 FGC wound, and it can improve some health implications, and it's usually necessary for childbirth and intercourse. In addition to physical health, FGC also has psychological consequences. These vary depending on the age of the child and when it was done. Some experience depression, anxiety, or PTSD. Women may develop a fear of sex because of pain or a fear of childbirth for the same reason. This has implications for relationships and marriage. For women migrating to Western countries, there may be a lot of confusion after migration, after the practice. There is a pervasive element of secrecy around FGC. Therefore, learning more about the psychological implications related to FGC has been very difficult for researchers. Much trust building is needed to tap more into the psychological impacts. As I mentioned, FGC is considered a violation of human rights, gender-based violence, and a form of child abuse. Around the world, more and more countries are making the practice illegal. In the U.S., it is considered illegal to perform FGC on anyone under the age of 18. Additionally, vacation cutting is considered illegal. This is where families travel or attempt to travel outside the U.S. to have it performed on their daughters and then travel back into the country. And while there are federal laws against FGC and vacation cutting, there are 26 states around the U.S. that have implemented more specific laws regarding the practice that are specific to criminalization and age requirements. And for more information on this, you could click on the link on the page for Equality Now's website. We have a lot of information regarding laws on FGC in varying different states, and also just some of the efforts that are going on globally to prevent or stop the practice of FGC. I also just want to point out that it is considered illegal to discriminate against women who have been cut. Remember that this is something that happens to girls at no choice of their own. Someone who has already been cut and is living in the U.S. is not and has not broken any laws. When working with women and girls affected by FGC, it's important to be aware of what they may be feeling and experiencing. Their experiences of FGC are often compounded by their experience as immigrants and refugees in a new country with very different cultural practices. We have to remember that they may have never even met a woman who is uncut, as they may be coming from cultural communities where the practice is widely accepted and expected. Now imagine coming to the U.S. where the practice is considered illegal and it is not tolerated or well known. And on top of it, it is referred to as mutilation and considered abnormal here, which may simply reinforce the trauma caused by FGC. This can leave some women feeling a sense of shame or confusion. They may also feel powerless as they sort through these feelings and what happened to them. These feelings could further push the practice underground and lead to isolation. It's important that we create welcoming environments for those affected by FGC and learn as much as we can about the practice. Additionally, you may be working with families who fled their country of origin to avoid FGC. While refugee and immigrant families try to navigate acculturation and hold on to aspects of their own culture that are good and adopt aspects of U.S. culture that are good, this is a factor they inevitably have to sort through. And so for those working with women and girls affected by FGC in the U.S., it's important to consider their feelings and consider their background and what they're experiencing as refugees in communities in the U.S. Women and girls affected by FGC experience intimate exposure of this with physicians in the medical setting when visiting for prenatal care or for a gynecological exam. Focus groups with women across the country have exposed varied experiences of women in these settings. Some have found access to culturally sensitive care, while others simply have not. It's important to remember that women who have been cut generally have this done by no decision of their own. Going to the doctor for gynecological or prenatal care is often a very different routine in some cultures. In the U.S., this is done much more frequently. Women affected by FGC may feel nervous talking about their own anatomy or embarrassed about going to the doctor in general, let alone communicating about FGC. This can often be a very difficult topic to talk about. They also have expressed troubles gaining access to trained interpreters. Some interpreters are not comfortable communicating about such private topics on reproductive health or FGC and may not communicate fully or accurately between the patient or the doctor. And this can prevent women from asking questions and communicating about important issues impacting their health. Finally, some women have experienced a lack of cultural sensitivity, including being made to feel as though they are at fault for being cut or being made a spectacle in the office by doctors showing their infibulation or their cut vaginas to medical students or nurses during the appointment. As such, it's critical to provide culturally competent care for women affected by FGC in the medical setting and to prevent isolating these communities. Refugee women in the U.S. may come from very different cultural perspectives on medical care and U.S. norms around gynecological care and prenatal and perinatal care. So providing education about what is expected in the U.S. and why is very important for these communities as they go to the doctor. It's important to be sure that there is availability of trained interpreters who are not their children, who are willing and able to communicate about such sensitive topics. Patients may even request female interpreters. It's also important to provide an explanation of the procedures being done with the patient and to explain why it's being done. Be sure to focus on their overall health and not just FGC. It's also important to be sensitive while conducting the procedures, as women may still feel physical or psychological pain from the cut. Healthcare professionals who don't feel confident providing medical care to someone affected by FGC should refer out to somebody who is more experienced. Also, to reiterate, women affected by FGC don't necessarily connect that the symptoms they are experiencing that are actually related to FGC, and they likely will not know what type of FGC they've undergone. For example, whether it's type 1 or 2 or 3. So medical professionals should educate themselves on the symptoms, know what to look for, and be prepared to ask poignant questions about their health and explain information regarding needed care. There are many resources on FGC for medical professionals on the World Health Organization's website, and I would encourage you, if you're interested in learning more, to check out that website, as well as others that we'll discuss at the end of the webinar. General social services from teachers, social workers, and refugee caseworkers should also be culturally competent. Most importantly, if you are working with somebody affected by FGC, learn more about the practice. And also look inwardly and examine your own beliefs and efforts to facilitate a safe, non-judgmental atmosphere for those seeking services. Also remember to offer mental health services to adults and children. This came up as a need. Mental health services came up as a need for those in more recent studies with women who have been affected by FGC. I want to spend a little bit of time talking about the risk factors associated with FGC and also factors that you may consider as evidence of FGC. So when you're working with women and girls in the U.S. who are affected by FGC, maybe it's in the school setting or the social service setting or in the medical setting, these are things that may be beneficial to keep an eye out for. So one is whether or not a girl talks about a visitor coming from abroad, particularly for a ceremony or a ritual to become a woman. Another is if a girl talks about a planned trip abroad, maybe during the summer or spring break, that's for a ceremony to become a woman. And then also maybe pair that with unexpected or prolonged absences from school or from social services. Now, there's also a few things that you can look out for in terms of whether or not, or in terms of evidence of whether or not FGC has been performed. You may notice that girls have difficulty walking, sitting, or standing. You may notice frequent trips to the bathroom. You also may notice unexpected or prolonged absences, or maybe an avoidance of medical exams. As we mentioned earlier, there are many girls at risk in the U.S., so these things are they're important to pay attention to as social service providers and teachers. And while they're important to consider, be sure to guard against stereotypes when assessing any situation. Remember that simply because somebody is from a country where FGC is practiced, it does not mean it's viewed favorably by their family. The risk factors noticed should not be considered in a silo, as they could indicate something very different. So consider creating guidelines which outline culturally appropriate and sensitive intervention strategies and reporting strategies for FGC in the school setting or other organizational settings where you work when you regularly come across women and girls that are affected by FGC. So if you suspect that a girl is at risk or has recently undergone FGC, you do have a responsibility to take action to protect this girl. Remember, if you are a mandated reporter, it's important that you follow through with Child Protective Services. However, FGC is unique, as it is often the case that mothers are not choosing to have this done out of malicious intent or intent to harm, but are doing so out of cultural norms and beliefs. So this does not make it right, but it makes the intervention complex. So importantly, intervention should work collaboratively with Child Protective Services, the family, and a cultural mediator in the community to inform the family of U.S. laws regarding the practice, any relevant state laws, and the health consequences of having this performed. Collaboration and communication with the family and the community that practice FGC is often the most effective way for preventing this in your community. There are alternatives to FGC, and you can help bring these to light. So speaking of that, we're going to spend a little bit of time talking about what are called alternative rites of passage. These are done to prevent the harmful implications of FGC. One effective way to prevent FGC is to implement these alternative rites of passages. And these are ceremonies that honor a girl's transition into womanhood in an ethnically and culturally relevant way, simply without the practice of FGC. The transition is marked in a safe and dignified way for everyone involved. Typically, cultural communities that celebrate these alternative rites of passage maintain cultural traditions and incorporate educational opportunities with mothers and daughters on topics like healthy dating relationships, maybe male and female anatomy, cultural education, and tips about protecting women and girls against sexual violence. Every culture emphasizes certain ethnic traditions more than others, with the overall goal of marking this unambiguous transition where female roles and responsibilities change and girls are honored and presented as women to their communities, generally in a public setting. These are alternative rites of practices are practiced in the U.S. and also around the world. And they uphold the tradition that many non-Western cultures value the marking of a passage from girlhood to womanhood in a concrete ritual. But it works to prevent FGC in all of these practices. So these are, the alternative rites of passage can be really awesome ceremonies, and I would encourage you to look into them if you're interested, especially if it's something that you think your community could benefit from. Raising awareness and preventing FGC may be very relevant in your community. And as you go about these efforts, I would encourage you to consider working with those most affected by FGC. It's important that their voices are lifted up most prominently in prevention efforts. Also, lift up the voices of community leaders, as that is where women and girls often take direction from. And so grassroots organizing and lifting up the voices of community leaders can be really effective ways to prevent and stop the practice of FGC. It's important to empower communities to be leaders for change. It's also important to provide education to teachers, Child Protective Services, staff in healthcare settings, and also cultural mediators about what FGC is, the cultural background of it, and some of the health implications of FGC. There's so much that can be done collaboratively to stop the practice and to break the silence. Now, across the U.S. and across countries, their communities are becoming more and more aware of the cultural practice, and they're responding in very unique ways to provide support and intervention strategies. One of the neat things we've seen is women's support groups, where women have the opportunity to dialogue and process their experience. Oftentimes in these women's support groups, it's the first time they've communicated about FGC with somebody else. As it is, or as it can be, a kind of a secretive thing in certain communities. There have also been health seminars focused on women, and these seminars often cover topics such as female anatomy, their health, but then also the practice of FGC and maybe some health implications that are caused by that. Cultural competency training is also important for medical professionals and social service providers. This is so that the most effective strategy for working with women and girls who have been affected by FGC and providing culturally competent services can be played out in a culturally sensitive way. As we mentioned just before, some other programmatic efforts we've seen in working with FGC is alternative rites of practices. And then we've also seen educational and empowerment programs for young girls. I want to just briefly cover a couple of places, and these are just a few different places where you can get some great resources on female genital cutting. BRYCS Community Conversation has an introduction to FGC fact sheet. This is also posted on this webinar, so you should be able to access that on the bottom of your screen before you leave the webinar today. This provides basic information about FGC, the cultural practice, and the harmful implications of the practice. Currently, BRYCS is in the process of releasing a few other resources. One is specifically for healthcare providers and gets into a bit more detail than what I covered today about culturally competent practice and some of the harmful health implications of the practice. BRYCS is also releasing a resource for teachers and social service providers that's focused on culturally competent practices, and then also some more details on risk factors associated with FGC and how to report FGC and follow through with that report with Child Protective Services in a culturally competent way. BRYCS is also working on a handbook that's intended for mothers and daughters from communities that practice FGC, that address the practice of FGC, but then also cover topics related to puberty and reproductive health and alternative rites of practice. And then the Office of Women's Health has many resources available as well. They also include a fact sheet and an FAQ on female genital cutting. And the names of these resources on the screen are the web pages as well. So if you click on those hyperlinks, that should take you directly to the resources. And then finally, I just want to mention that the World Health Organization has various resources, including a handbook for the management of health complications of FGC. So the World Health Organization, though they have various fact sheets and one-pagers and informational sheets about female genital cutting and its implications, they also have a lot of resources and information geared towards health providers. So that's an important one to check out if you're working in the medical setting, especially with women who are affected by female genital cutting. All right, and from that, I want to go ahead and address some of the questions that I've seen in the chat box. So we've gone through the topic for the webinar today, and I'll spend the next 15 or 20 minutes addressing some of the questions in the chat box. If you have any questions right now or things that have come up from listening today, please feel free to put that in the chat box now, and I'll make sure to get to as many as possible before our time is up today. So one of the questions, this is a great question, how do you find the balance between making sure staff and students are trained and see patients with FGC and making sure that the patient does not feel like they are being paraded with a bunch of non-essential staff or non-essential information? One of the things that I think is really important in the medical setting is simply to ask questions. A lot of times this is something that's not necessarily commonly talked about with patients who have been affected by FGC, and asking questions about what the patient feels comfortable with can be really important in this setting. So even just asking the question, are you okay if I ask you questions about female genital cutting? Or are you okay if I ask you questions about your experience of female genital cutting? Or are you okay if we have another person come in here to examine you? Those types of questions are really just really critical to making sure that the patient feels the most comfortable in those settings. And if they say no, if they say they don't want to talk about it, then respect that. For some women, it can be very difficult to talk about, and it can bring up a lot of maybe emotional feelings, or maybe simply for some women it's just a conversation that they're not used to having. So I think asking those questions in the beginning are really, it's just a really important way for creating a positive path forward in the medical setting. There's another question about other names for FGC among the various cultures where it's practiced. I mentioned Suna and Khatna. There's also circumcision. Those are some of the most common that I've come across. There may certainly be more in various cultural groups. None of them are coming to me off the top of my head. But I know when working with some of these cultural communities who practice FGC, using the term female circumcision is widely recognized. And then, if you're interested in learning more, it could just be a simple question posed to that community. How would you like me to refer to this? And oftentimes female circumcision has come up as the most widely desired term. Yeah, somebody just asked if there are recommendations for how to broach this topic with a patient that you suspect has undergone FGC, so as to avoid any victimization and stereotyping. And I think I'm just going to kind of go back to the other question that I addressed and just really asking questions and getting a sense for what the patient is most comfortable with. So making sure, are they comfortable with you examining them, and are they comfortable with you asking questions about female genital cutting, and just letting them know that you're there to help, letting them know that you're there to help sort through the physical complications that they may be experiencing from FGC, or if they're in for prenatal care, just being very attentive to their needs, letting them know some of the implications of FGC during prenatal care and during pregnancy, and making sure to work together with the patient and providing that education so she feels on board with the physician or the nurse in the exam room. Yeah, and then another important thing to mention is that BRYCS will be releasing a brochure for healthcare providers working with women who have been affected by female genital cutting. And on this brochure, we've laid out cultural considerations for working with women and girls affected by FGC, and then maybe also just some examples of questions to ask patients, and also some of the physical implications that women may be experiencing as victims of FGC. So when they're in that medical setting, healthcare teams can be well prepared to sit across with a woman who's been impacted by FGC and help her sort through the implications of that. Somebody asked, is the fact that FGC is illegal, is that covered in overseas orientation? And honestly, I don't know the answer to that question. This is a great question, and it's something that we can certainly look into, but I'm not sure if it's covered in overseas orientation, and if it is, maybe it's not covered consistently. But we can certainly look into that. I think that's a really great question. Yeah, and then I just saw a little bit of back and forth on the names. So I'm referring to it as female genital cutting for the purposes of this webinar. It's also referred by other organizations, such as the World Health Organization, as female genital mutilation. And I'll just quickly recap. As I said in the beginning of the slide, sometimes female genital mutilation has been seen as an offensive term for those communities that practice it. and it's a term that is not created by those communities. It's something that was created in Western countries. And so we use female genital cutting. It's also female genital circumcision and suna and katna and various other different names. So the penalty in the U.S. for performing FGC in the medical setting, it generally involves, at least in terms of federal law, it generally involves some number of years of jail time as well as a fine. States, though, there are 26 states across the U.S. who have increased the number of years of jail time and also increased what that time or what the penalty would be, at least compared to the federal law. So it really depends on what state you're living in and what state it's performed in. Oh, and Florence mentioned that at their clinic that they provide women with a card that notifies the practitioner that she has undergone the practice, and this helps facilitate communication. And that's a really great idea. It reduces risk during pregnancy. It can keep things anonymous or at least information secure in the medical setting. One of the things for the brochure that BRYCS is creating for medical providers, one of the things that we hope will happen with this is, of course, we want this to be an educational sheet for providers in the medical setting, but we also hope that women will take this sheet with them when they go to doctors' offices so that they can hand it to a doctor or hand it to a nurse and maybe just simply say, you know, I've been affected by FGC, I just want you to have this sheet. And then that can provide the doctor with some culturally appropriate tips for how to serve these women. One of the other really neat things for how this brochure is being created is that it's basically the information in the brochure is coming from the women themselves, right? So this brochure came out of focus groups that took place around the country asking women what their experiences have been in the medical setting and what they hope for in terms of care from the doctor. And so using all that information, we compiled it into this one brochure. And so we're really hoping that that can be a resource for practitioners, but it can also be a way for women to communicate about their experiences of FGC. So Florence, thanks for bringing that up. I think that's a really great strategy. And it sounds like it's something that's working for you guys. Somebody asked if chaplains are used in the care of FGC victims. I'm assuming, Kimberly, that you're thinking of chaplains maybe in the medical setting. And I don't know. I've not heard of that. Not to say that it's not being done, and each healthcare facility has their own sort of procedures around this. I know there are certainly medical, there are certainly healthcare settings where women are referred out for mental health services, if that's something that seems like it could be relevant for them. But whether or not chaplains are used, I'm unsure, and likely that varies. Yeah, so do medical providers that perform FGC lose their medical license? In the U.S., I think, again, this varies by state. I think there are some states where that certainly can happen, and I think it depends on the number of times that it's been performed by that medical provider. But again, that would certainly vary by the state in which it's been practiced. Is it necessary to discuss FGC at the initial orientation with newly arrived refugees? And that's a really good question. I certainly think it's an important topic to cover in an orientation with refugees, whether it's the first thing that comes out maybe there's a way to position that so that there's a little bit of trust building that takes place before it's mentioned. There are, as I mentioned, BRYCS is releasing some resources that can help foster this discussion, so stay tuned for those. And one of the really neat resources is a handbook that BRYCS is creating that's for women and girls from communities that are affected by FGC. And it's really intended to be a handbook that they would go through together, so it will have a page for mom and a page for daughter, or a page for caregiver and a page for daughter, and really something that will just engender a fruitful conversation between mother and daughter about female genital cutting and about womanhood and about puberty and those sorts of topics, so that it can help address that conversation in the home. But I do think that female genital cutting is something that should be addressed at some stage in orientation with an arriving refugee family. So there's another question about what is the risk during pregnancy if a woman has undergone FGC. Does the risk of miscarriage increase? So this really depends on the type of female genital cutting that the woman has undergone. And in the most extensive form, type 3, usually is the one that has where there can be the most health implications during pregnancy. Oftentimes doctors will discuss de-infibulation with the woman, so this is where that wound, that sutured wound, is reopened back up to ensure a smoother delivery of the baby. If that doesn't happen, there is a risk that a child that the child could die during childbirth. There's also health risk for the mother if that happens. It's something that I'm not a medical professional, but also is something that should be talked about de-infibulation should be talked about being done prior to delivery, because that can also ease some of the gynecological exams that should take place during prenatal care. And one of the other things I just want to talk about really quickly is that when women who have undergone type 3 female genital cutting, there's often an assumption that a C-section is needed, but that's not necessarily the case. So it's important that a medical provider is doing research on this and finding ways to deliver a safe and healthy baby for women who have undergone FGC. It's also important to note that C-sections are sort of culturally not desired, or in many cultures is not desired, and so that's also something to consider in this process. And so working together with the soon-to-be mother or the patient who's undergone FGC, working together with her to create a health plan that's safe for her and safe for the delivery of the baby is really important. But it obviously depends on the female body and the type of female genital cutting she's undergone. Yeah, and Florence brings up a really good point. Just suggest reading the country backgrounder for your clients, and just paying attention to some of the countries where the practice is where it is practiced predominantly. That's just a really important thing to do if you're a medical professional. Yeah, so there's one, typical age for FGC. So it can be performed on girls from infancy to early teens, but usually most commonly it's performed on girls from ages 7 to 11. So that's certainly an age of memory, which is something to consider, obviously for the physical health implications, but also for some of the mental health implications that could come from this, because it's something that's often remembered and that there can be flashbacks to that experience. So, and then there's one final question about ways to educate potentially affected clients and families, or those families that may be affected in the future, or those young girls that may be affected in the future. And this is where this is such a good question, and it's something that's just really important to consider, and to make sure that you're educating yourself as much as possible on on the practice, the implications it could have on the culture, and what that cultural community that you're working with, what their beliefs are right now. So I'm assuming this is working with a cultural community in the U.S. that may in the future be affected, or that may have clients affected by it. And it's really important to understand what their current beliefs are. Some ways, I mean, there's obviously ways to empower women through health education classes, through women's support groups, through female empowerment programs and educational opportunities, and then also through educational opportunities about gender-based violence. These can be done in the school setting, at a refugee resettlement agency, or at a community center. But one of the key things, I think, to addressing and preventing this in community is partnering with local community centers or cultural centers where some of these cultures may congregate, and to partner with some of the cultural mediators and partner with some of the cultural leaders. Because oftentimes women and girls are following the direction of their cultural leaders. And so it's really important that this is a grassroots effort where hearts and minds are changed within that cultural community, and in a simple sort of public health message about how this is unhealthy and a practice that has negative health implications generally is not the most effective way to preventing this. But working together with cultural leaders, working together with women in those communities and with men in those communities to say no to FGC is one of the most important approaches to this. So that takes a lot of time, it takes a lot of effort, and it takes a lot of sort of back and forth and learning about those cultural communities. So if you have further questions on that, feel free to connect with us offline, and then hopefully some of our resources that are coming out can also help facilitate some of these conversations. Yeah, and there's a comment that gender-specific cultural orientation sessions have been found effective in some resettlement programs, and Marisa, just a shout out to that. That's so true, and is a way to create a more intimate conversation about FGC and how women are impacted by it, how girls are impacted by it, but then also how men are impacted by it, because there are certainly relational aspects to this. Yep, and there's other suggestions for support groups, cultural events, and those are cultural events, support groups. Actually, cultural events and maybe like women's health educational events. These are often just sort of great ways for that initial trust building, and that initial trust building then can lead to maybe forming support groups for women and girls or men who have been affected by this. So it's really important to take sort of those baby steps to build trust, and then start to hear the needs of the community, and then from there figure out ways to get in and provide education. Yeah, another question about is FGC covered through overseas orientation, and I have to say I can't confidently answer that with yes. It's always provided in overseas orientation. I think that it certainly. I can't say confidently that it's consistently provided, but that is something that we can check into. Any other questions that anyone has from the webinar, or just things that we didn't address today? I just want to say it's been, it's good to see such a great turnout. It's good to see so much interest in this topic. And it's certainly something that we encourage you to keep an eye out for further resources as you continue to work with women and girls affected by FGC.
Thank you, everyone, for all of your wonderful questions. If we didn't get to yours today, we will definitely continue to discuss this on our blog, which you can find a link to at the end of this webinar. Feel free to contact us with any questions or concerns. You can reach us at info@brycs.org. number and then through our website as well. This has been recorded, so we'll send it out in the next 24 hours to you all. And please feel free to complete our evaluation survey so we can get a better idea of what you'd like to learn more about and any resources or information you think that would be helpful. And then, as always, keep an eye out on our website. We will be, as Jenny said, releasing more resources for medical providers, resettlement agencies, educators, and so thank you for joining us today, and let us know if you have any other questions. Thank you.